Okay, we'll start back up again. Based on the last number of hours, I think we all could agree that we need more evidence, but even more insights into what evidence already exists. And this next section that we've titled What Works? Results of a Systematic Review is going to be presented by Alex Rowe. Several of us are very excited about this because we've been involved in ongoing conversations with Alex, who has worked with a number of you around the table, and is really breaking down a massive data set to try to understand what are some of the component parts and some of the effect estimates. So let me just introduce Alex to you. Alex Rowe is a medical epidemiologist with CDC's Malaria Division. He's worked at CDC since 1994 in several areas: the Chronic Disease Center, International Child Survival Unit, and malaria. His key interests include improving health worker performance in developing countries, and he's authored many scientific publications, and I feel like it's fair to say that his wife has been a collaborator in this work, although she's not with us today. Alex.
Great, thank you very much. It's a real pleasure to be here. So let me begin with a few acknowledgments. Results in this presentation are derived from the Healthcare Provider Performance Review. And on this slide are my co-investigators. First, Samantha Rowe at CDC, David Peters at Johns Hopkins University, Kathy Holloway at WHO, John Chalker at MSH, and Dennis Ross Degnan at Harvard Medical School. I'd also like to acknowledge the many people who have worked on this project over the years. Give a special thanks to investigators who responded to our queries, some of whom are in this room, so thank you, and a generous financial support from the Bill and Melinda Gates Foundation, CDC, and the World Bank. So clearly, improving health worker performance in low and middle income countries is essential for improving health and reducing death and illness. The Institute of Medicine and USAID are interested in the effectiveness of strategies to improve performance that are often funded by USAID. And we're now aware of the 6 strategies that are being examined in this workshop. So IOM contacted the investigators of the Healthcare Provider Performance Review, which is a systematic review of all strategies to improve healthcare provider performance in low and middle income countries. And I'll talk about that momentarily. And the objective was to use the results from this larger review to evaluate the effectiveness of the 6 targeted strategies. So methods. And let me begin by saying, please note any methodological issues or suggestions that you have. The methods are a little bit complicated, and some of the methodological decisions were based on our team's best judgment, but we recognize that other choices could be justified. So please, write down your concerns and suggestions, raise them during the discussion, or email them to me. My email address is up here. And I wanted to let you know these are preliminary results, so we will be repeating the analysis, and we can consider other methodological options. We can also produce sensitivity analyses that use alternative methods to see how much those methods affect the final result. So all that's on the table. Okay, so now the inclusion criteria for the larger review, the Healthcare Provider Performance Review. We included any study with an eligible study design, and I'll describe that momentarily, any study of the effectiveness of any strategy to improve healthcare provider performance in a low or middle income country on any health topic in any language, published or not. We defined healthcare provider quite broadly as any facility or community-based health worker, but also we include pharmacists, shopkeepers who sell drugs, and health workers in the private sector. Here are the eligible study designs. So we include pre-intervention versus post-intervention studies with a comparison group with or without randomization, post-intervention only studies with randomized controls, and interrupted time series studies with at least 3 data points before and after the intervention. For the literature search, we searched 15 electronic databases. A few of these are on the slide, and that was, the search was completed in 2006. So it's out of date. Second, we reviewed personal libraries and asked colleagues for references and unpublished studies. Third, we searched document inventories of 30 organizations involved in performance for unpublished studies, and that was completed in 2008. We conducted a hand search of bibliographies from 510 previous reviews and other articles, and then during the review, which has taken quite a few years, 17 authors of included studies have sent additional new reports related to their studies. Titles and abstracts from the search were screened. We performed double independent abstraction, and data were entered into an Access database. Queries were often sent to study authors for clarifications, details on methods and the context, and so forth. And as a result, to some degree, the Healthcare Provider Performance Reviews database contains more than what's in the original reports, although the database in no way replaces the reports. So defining strategies for the IOM analysis. So our goal was to develop a definition for each targeted strategy so that studies of these strategies could be identified in the larger database. The database has over 150 variables that code for the presence of individual strategy components. So for example, training and supervision would be considered separate components. And then the strategy definitions are based on these 150 plus component variables. And I want to make a note at the bottom of this slide that there is no universally recognized taxonomy of strategies to improve performance. And so these definitions really should be considered as working definitions for the purpose of this analysis and not some kind of absolute. Okay, so here's what we came up with. So first is two categories for training, because a priori we broke this down. There were many, many studies on training. And so we thought it would be useful to have two levels of training to indicate two intensity levels, if you will. So high intensity training only. So that's training with a duration greater than 5 days, or ongoing training with at least one interactive method. That is clinical practice, interactive sessions, or role play, and no other components. There's a tiny asterisk there that I'll explain in a moment. Low intensity training only, so that's any training that's not high intensity training with no additional components. And so the asterisk here is that this definition excludes academic detailing and informal education by a peer. And these can be thought of as educational activities, but the IOM preferred to kind of keep these separate, which is fine, just to let you know that. In addition, in this analysis, training is allowed to include job aids or printed educational materials for the healthcare providers, because in the real world this happens all the time. And so, and as part of these studies, so that's kind of, it's training, and it allows, you know, there can be job aids or printed educational materials for health workers. The two are kind of bound together, if you will. Fourth is accreditation only, and that's a strategy with only the following component: licensing, certification, accreditation, or registration. And I'm sure one of the earlier speakers on accreditation will cringe at this, because it's overlumping, but as you'll see in the results, it doesn't have a practical impact at this point. Fifth is improvement collaborative only, so those are the improvement collaboratives as defined by the authors of the report, again with no additional components. Sixth is the client-oriented provider efficient or COPE method only. And I want to point out that we did not have any COPE studies that were in the database when we started. And so what we did was we created a definition for a COPE-like strategy. And that was defined as having all of the following components: provider self-assessment, continuous quality improvement, which includes team-based problem solving, and peer review, but no other components besides that. And then standards-based management and recognition, or SBMR only. And similarly to COPE, there were no SBMR studies in the database at the time. And so we created an SBMR-like strategy, which was defined as having all of the things on the bottom of, or in the middle of this slide. So standard health facility specifications, health facility received recognition, HCP self-assessment, team-based problem solving, supervision, and low-intensity training, with a slight twist on the definition, but mostly as I described earlier. So all of those together and nothing else. And then we have certain combined strategies, and these are all based on previously defined strategies. So high-intensity training plus supervision, low-intensity training plus supervision, and low-intensity training plus improvement collaborative. Okay, study outcomes. The study used a really wide variety of outcomes, and we felt that it was probably inappropriate to include all of them in the same analysis. So for example, including outcomes on mortality and history taking simply doesn't make sense to combine those. So for more of an apples to apples comparison, this analysis only includes outcomes on processes of care expressed as a percentage. And examples would be the proportion of patients correctly assessed, diagnosed, treated, counseled, or referred. So these are direct behaviors of healthcare providers. Results are also stratified by healthcare provider type, and there are two groups. The first is a group that can include any type of healthcare provider, and this is the main group of studies, and it includes everything except those studies that focused only on lay health workers or community health workers. And we stratified in this way because lay health workers are different in many important ways from nurses and physicians and so forth. And not only that, but the interventions that you use to change their performance are often quite different, even though the labels are the same. So we felt that it was important to stratify on this attribute. Okay, risk of bias. This method was that we used is based on methods developed by the Cochrane Effective Practice and Organization of Care group. The risk of bias was determined at the study level, and the elements considered are shown at this third bullet point. So study design, number of clusters per arm, data completeness, similar outcome levels at baseline, outcome reliability, concealment of allocation for studies with randomization at the patient level, whether the intervention likely was to affect data collection, the presence of non-intervention changes, that's only for interrupted time series, studies, and having fewer than 6 data points before and after the intervention, also only for interrupted time series. And the final categories are shown at the bottom of this slide. So there are 4 categories in the end. We take all this information, put it together, and there's low risk of bias, moderate, high, and very high risk of bias. Okay, effect sizes. These were all calculated in terms of an absolute percentage point change. An example formula for outcomes expressed as a percentage is shown here in blue. So the effect size is the follow-up value minus the baseline value in the intervention group minus follow-up minus baseline among controls. So for those of you that don't think so much about effect sizes in absolute terms, so here's a very simple example. Let's try if I get this on the left side. So in the intervention group, let's say it goes from your outcome, let's say the proportion of patients correctly treated goes from 20% to 50%. So that's a 30 percentage point improvement. And let's say among the controls, it goes from 25%, and let's just say it increases a little bit to 30%. So a 5 percentage point change, and then the difference of the differences is 25 percentage points. And the interpretation can be thought of as this way. For every 100 patients that are seen, 25 patients are correctly treated that can be attributed to the intervention. So that's one way to think about this example effect size. We calculated effect sizes such that positive values mean improvement, and that's because some outcomes are designed to decrease, so those results needed to be flipped around for comparability. And effect sizes for interrupted time series are calculated with a similar approach, but segmented regression modeling was used, and I'm happy to describe that method, but I have to cut a lot of methods, a lot of things out of this presentation to keep within time, so apologies for that. Okay, the primary analysis only includes a strategy versus a no intervention control comparison, so there are no head-to-head studies in this analysis. The review has lots of head-to-head studies, but those aren't included here. And results from studies with more than one primary outcome are summarized by a median effect size. So the issue here is that many studies have more than one primary outcome. So if, for example, you have a study with 3 outcomes, if you have 3 outcomes, that means you have 3 effect sizes, and we took the median value to represent that study. And then we compare median effect size distributions of the various strategies that we'll be examining. and we use weighted medians and interquartile ranges. And the one exception here is we use unweighted medians if the number of studies is less than 5. For the weights, it's this expression here. So it's 1 plus the natural logarithm of the number of healthcare providers in the study, or if that's not available, the number of service provision sites. And this is a very crude proxy of the scope and size of the study. And we know that it's recognized it's very imperfect, but these studies are so heterogeneous that we thought that this was at least a rough proxy for that. And then to reduce confounding, effect sizes were adjusted for differences in effect modifiers. And by that, I mean factors that influence effect size regardless of the strategy. And empirically, in the larger database, we found 2, baseline performance level and public health facility setting. Let me try to explain this. So for baseline performance level, we found empirically that for every 10 percentage point increase in the baseline, the effect size decreased by 2 percentage points on average. And if you think about that, if you're starting at a higher level, there's less room to improve, so your effect sizes will tend to be a bit smaller. And you can think about this as being a bit of a disadvantage. If you're starting out at a higher level, it's just harder to have a larger effect size, again, regardless of the strategy. And just to show you a picture of that, this is from the larger database, so you can see baseline performance level on the x-axis and effect size on the y-axis, and you can see decreasing effect sizes on average as you increase the baseline performance level. So here's an example of the adjustment. It turns out in the larger database, when looking at processes of care, the mean baseline level is 41%. So in your mind, picture a clinic someplace in a developing country, and patients are getting seen. And for every 100 patients that are supposed to be diagnosed or treated or counseled, on average, before implementing a strategy to improve performance for studies in the review, only 41 patients, only 41% are getting whatever it is they need done. So if the baseline for a particular effect size is 51%, so 10 percentage points higher than the mean, then the adjustment would increase the effect size by 2 percentage points. So it's sort of removing part of that disadvantage that you get, this contextual, that's a kind of a contextual factor, if you will. And then for public health facility setting, we did something similar. We found empirically that the mean effect size is 8 percentage points higher than in other settings, again, regardless of the strategy. So whatever you do, if you test it in a public health facility only setting, you're likely to get larger effect sizes. And I'll leave it to you to think about what those reasons might be. And the goal is important here. What we're trying to do with this adjustment is adjust the results to a partly standard context. In other words, for example, what would the results have been like if all of the studies had the same baseline level of performance? So it's a way of trying to equalize out some of the biases, some of the confounding due to different contexts. It's a very crude method, but we think that at least it removes part of the confounding. Certainly not all of it, but part of it. Okay, a little bit more on confounding. For strategies with the greatest levels of effectiveness, we checked for something called confounding by limited variability, which is a horrible phrase, but what we're trying to get at is we're asking the question, are high effect sizes due to studies coming from settings that just happen to be unusually well suited for this strategy? And so what we do is we broaden the strategy definition to include more studies with the same basic strategy and see if the results change. A large decrease in effect size indicates that this confounding could be present. And there's an assumption that adding additional components would not decrease effectiveness. And this probably sounds a little bit cryptic. I'll go through a real-life example for you, with you in a few minutes. Let me just move ahead to save time. Okay, secondary analyses, and these are not yet done, but something that we can consider. And those include meta-analysis and meta-regression. And these methods account for study size more quantitatively and summarizes effectiveness in terms of means and confidence intervals, which has some advantages over medians and interquartile ranges. And then there's network meta-analysis, a relatively new analytic method in systematic reviews. And it's like meta-analysis, but it also includes quantitatively results from head-to-head comparisons. So these are things that, if they're of value, we can consider exploring these. Now, you might be asking, the question, why aren't these the primary analyses? Because if you look at a systematic review today, you often will see meta-analysis. So why aren't we doing that? And the answer is that we have real concerns about the validity of sample sizes and thus analysis weights, and that's one of the key advantages of these methods. And the issue is that most studies use a cluster design. For example, patients are clustered within health facilities. So one can't use, for example, simply the number of patients from a study. And most studies don't include enough information to accurately estimate the effective sample size. So this is a real problem with the primary studies. It's a little bit less so today, but kind of in the studies from past decades, it's just a limitation. Okay, so we're 19 minutes into it, and now we're starting the results. Sorry about that, especially at this time. Okay, so literature search and descriptive results of the included studies. So for the larger review, over 105,000 citations were screened. This took about 3 years. And 824 reports were included. And again, this is the larger review. 66% of those reports were published in scientific journals. That means a third of the studies were unpublished. That's good. That means we have quite a bit of gray literature. And the 824 reports corresponded to 489 studies, distinct studies that were included, again, in the larger review. Okay, then going into the IOM analysis, we're going to look at a subset of those studies. And so 66 studies were included in the IOM analysis on the targeted strategies. And they include 71 comparisons of an active strategy versus a no intervention control group, or a historical control for the interrupted time series. Okay, so here are the strategies that we were hoping to look at. And you can see the number of comparisons on the right. So high intensity training only, there were 7 comparisons. Low intensity training only, 35. Supervision only, 6. Accreditation only, 0. Improvement collaborative only, 7. This COPE-like strategy only, 0. SBMR-like strategy, 0. High intensity training plus supervision, 4. Low intensity training plus supervision, 5, and low intensity training plus improvement collaborative, 3 comparisons. So what I'm going to do is remove the rows that have zeros, because there's nothing more we can say about that quantitatively. And I'd like to look at the remaining ones to examine risk of bias. Okay, so I mentioned earlier that risk of bias is in 4 categories, so I've grouped them together for simplicity to low or moderate risk of bias, so that's good, that's in green, and then there's high or very high risk of bias, which obviously is more problematic, and that's in red. So high intensity training only, there were 7 comparisons. 4 of those had a low or moderate risk of bias, 3 had high or very high risk of bias. Low intensity training only, 15 and 20. Supervision only was 3 and 3. Improvement collaborative only, all of those were high or very high risk of bias. High intensity training plus supervision, all 4 were high or very high risk of bias. Low intensity training and supervision, 2 and 3. And low intensity training plus improvement collaborative, all 3 were high or very high risk of bias. And again, I'm happy to go into the details at any point, but okay, overall risk of bias. So looking across all the studies, again, this paints the picture that other people have commented on. The strength of the literature is generally weak. So 11% of studies had low risk of bias, 23% moderate, 36% high, and 30% very high risk of bias. Where were the studies done? So they were from 33 countries, some were from multiple countries, and 56% of studies were from low-income countries, so the rest were in middle-income countries. And the pie chart in the middle of this slide shows the geographical distribution, so you can see a majority in Africa and Southeast Asia. For study designs, 27 studies were pre-post studies with randomized controls, 22 were pre-post studies with non-randomized controls, 13 were interrupted time series, and 4 were post-only studies with randomized controls. So, in other words, we found 31 randomized controlled trials. So that's nearly half, not bad. When were the studies conducted? So this shows the midpoint year of the study, and not surprisingly, they were from the 90s and the 2000s. For study context, we could spend the whole presentation just on this, but very, very briefly. There was we had studies from urban areas, peri-urban areas, rural areas only, lots from mixed settings. For type of health facilities or settings, public or government facilities, that was 61% of studies. Anything in the private sector, 21%. And then there are kind of other kinds of settings, often in the household or community level. There were studies done in outpatient health facilities, outpatient departments of hospitals, inpatient wards, community settings, and so forth. Just a lot of different settings. And many of these, there were multiple settings. It was very common. Types of healthcare providers. About half of studies involved nurses or midwives. About half involved physicians. But there were also many other types of healthcare providers, nursing aides, pharmacists, lab workers, and so forth. And I want to point out that there were 8 studies that included any type of lay health workers, but 4 of those 8 studies were predominantly on lay health workers, okay? And those are the 4 studies I'm going to peel off and talk to you about a little bit separately from the rest of the group. Health topics. There were quite a few studies, about 40%. Described multiple conditions or measured outcomes that related to all health conditions, but there were also acute infectious diseases, HIV/AIDS, a lot on newborn health, reproductive health, and so forth. Sorry for rushing through this. Data collection method, just knew this is a down payment on the question you asked earlier. So 70% of studies used a record review, but there were also interviewers of patients and caretakers and health care providers, observations of clinical interactions, simulated clients in some instances, and re-examination of the patients occasionally. Results on cost and cost effectiveness. So there was a wide variety of cost and cost effectiveness data reported, and at this time we don't have any quantitative synthesis, but I thought I would at least give you some descriptive results. So 26% of studies reported any information on strategy costs or other economic evaluation. So basically three quarters of studies had no information whatsoever. 12% reported cost on at least one strategy component. 23% compared strategy costs of 2 or more study groups. And 20% compared strategy costs of 2 or more study groups in terms of a cost ratio. For example, cost per service provided, which is a more portable type of outcome as in an economic sense. Okay, now the effectiveness of studies. So 26 minutes into our presentation, and I'm now only just talking about the effectiveness. Sorry for that. And as a reminder, these are all processes of care. For example, the proportion of patients treated correctly. Okay, and I'll start with the main group of studies. And again, this is anything except for studies that focus just on lay health workers or community health workers. Okay, so I will show the strategy and then the number of comparisons to give you a sense of how much evidence there is, and then the median and a little box plot to give you a sense of the variability of effect sizes for each of the strategies. And then the box plot is up against this x-axis on the bottom, which is the effect size. And as a reminder, that's an absolute percentage point change. And I've ordered these. So starting at the bottom, supervision only. So you can see that there were 6 comparisons. So that tells you, again, how much evidence there, gives you a sense of how much evidence there is. And you can see in blue, the weighted median of these adjusted median effect sizes is 7 percentage points. And the median is here in the box plot, in the yellow box plot. And then the borders of the yellow rectangle show you indicate the interquartile range. Okay, so that's supervision only. And then there's low intensity training only, 35 comparisons, and the median effect size was 7 percentage points. And as a quick reminder, high intensity training had a duration greater than 5 days plus at least one interactive method, educational method, and low intensity training was everything else. Low intensity training plus supervision, 9. High intensity training only, 12. High intensity training plus supervision, 15. Improvement collaboratives only, 21. And low intensity training plus improvement collaborative, 60. Okay, 2 issues related to potential confounding. The first is confounding by limited variability. So this is what I just showed you, and I'm going to take a look at the top one here, right? It's a very, very high effectiveness levels. And so this is how the analysis is going to work. So you can see up here is the original definition of that strategy, improvement collaborative plus low intensity training. And there are 3 comparisons, and the median effect size was 60 percentage points. So that was just what I showed you, except now it's more in words and there's no box plot. And so the idea is to now broaden the definition. And this is how we did it. We broadened it to group problem solving plus low intensity training plus or minus other components. So the idea is that broadening the definition adds similar studies, not exactly the same, but similar studies to improve the generalizability, and those studies have extra components. We assume that these extra components are unlikely to decrease sample size, decrease effect size. Theory has it that they might increase effect size, but at least we think that they're less likely to decrease effect size. And if the effect size decreases, then confounding is a distinct possibility. Okay, so it turns out when you apply this broadened definition, you keep your original 3 studies, but we found 3 more. So now we have a group of 6 studies. Okay, what were the additional 3 studies that we found? Okay, so the first was training plus continuous quality improvement plus community education meetings plus home visits plus printed materials for the community. The second, training plus team-based problem solving plus audit with feedback plus peer review plus group process plus poster. And the third was training plus problem solving meetings plus printed standard treatment guidelines, a poster, and audit with feedback. So all of these 3 added studies have this core strategy group of training plus continuous quality improvement or group problem solving. It's not the same as an improvement collaborative, but the idea is that it's a similar family of interventions, I think. Okay, so now that we've added these 3 additional studies that have these additional components, what happens to the effect size now? Well, it drops from 60 down to 11 percentage points. And so what that's saying is that if you broaden the definition to increase the generalizability, you find that there's this big, big drop in effect size, which raises the concern about the generalizability of the 3 original studies. And when you look at those studies, it makes sense. They were all done by the same group in the same country on the same health topics. So we're not saying that there's anything wrong with those studies, but just that there's something particular about that context that made that intervention particularly well suited. So that's, just keep that in mind. Okay, the second potential confounding issue is risk of bias. So back to the graphic that I showed with all the results. And it turns out for the 3 strategies with the highest with the greatest median effect size, all studies have high or very high risk of bias. Okay, context-specific analyses. There were 1 or 2 questions that were getting at the issue of what works where. And this is an absolutely critical question from a practical perspective. And so taking a very small baby step in this direction, I stratified the results according to whether the study was done in a low-income country or a middle-income country. Very, very crude approach. And I had to cut out all the results because there wasn't enough time, but the bottom line is that this approach kind of conceptually was useful, but in this particular case was not so useful because of small sample size issues. And again, I'm happy to share those results. In the larger review, this method actually had some interesting findings, but for this subgroup of studies, small sample size ended up being an important limitation. But again, I'm happy to share those results at another time. Okay, now results from studies that focus predominantly on lay health workers. So there were just 4 comparisons from 4 studies. All were from low-income countries and all had a high or very high risk of bias. There was 1 study, there were 2 studies on high-intensity training only, and the median effect size was 10 percentage points. There was 1 study on low-intensity training, and that had a median or an effect size of 14 percentage points. And 1 study on supervision, and that was 29 percentage points, so very small numbers of studies. Okay, factors associated with the effectiveness of training and supervision. I think there were 1 or 2 questions in the last panel discussion about that. And I'm cutting out about half an hour worth of results and methods, and I'm just going to get it right down to a quick summary. So apologies for that. The goal of this analysis was to identify attributes of more effective training and supervision strategies, and these were analyzed separately. So the idea is to take training and take supervision, drill down into those groups of studies, and try to see if you can figure out what makes them more effective. We used mixed linear regression modeling of any strategy in the full HCPPR database that had training or supervision in their strategy. For training, we found kind of one main significant finding, and that was that if the training was done on a single topic, training duration was not associated with effectiveness. We were quite interested on training duration, right? Because if you train for longer days, that's better. And it turns out when it's a single topic, there's no association with effectiveness. In contrast, if you have if you're doing a training on multiple topics, so for example, multiple infectious diseases, the effect size increased by an average of 1 to 2 percentage points per extra day of training. And then the single and multi-topic trainings were kind of hit an equivalency mark at 5 days, which I'm sure is quite cryptic. So let me show you a picture very, very quickly. So training duration is the x-axis of this, and effect size is on the y-axis. And so in green, you can see the single topic trainings, and it looks like it's a downward trend, but that's indistinguishable, is statistically indistinguishable from a flat line. So don't get fooled by that. But in contrast, the blue line, which is for multiple topic trainings, that's a significant trend. So for multi-topic trainings, if you have very, very short trainings, sort of just 1 day, which is, I'm sure intuitively doesn't sound like a good idea, you have lower than expected effect sizes. But as you increase the duration of training, it gets up to 5 days, and that's where it meets the single topic training level. And then as you continue to increase the duration of training, the studies are predicting that your effect size would continue to increase. Okay, for supervision, we found that when the supervision process explicitly includes feedback to the healthcare providers, that was associated with an 11 percentage point improvement in effectiveness. There's a very important limitation on the bottom of this slide. For all of these models, there were a lot of missing values, and so there was substantial risk of bias and confounding. So you have to take all of this with a grain of salt. These are just preliminary results, and unfortunately, we're just really limited by what's in the primary studies. Okay, so limitations. So there were no studies on COPE, SBMR, or accreditation only in the database, but as I've mentioned, this is out of date. Attempts to create a COPE-like or SBMR-like strategy, those were unsuccessful. But there are COPE and SBMR studies that are not in the larger database, and these need to be examined clearly. There are limitations of the studies themselves. I've highlighted a few already. And there's been insufficient time to examine cost data or results for other outcomes such as health impact, utilization, patient health worker motivation or satisfaction, that sort of thing. A few very preliminary conclusions and recommendations. So again, all focused on improving processes of care, and these are settings that are not predominantly for lay health workers. First, the objective of the analysis, I think, was not fully achieved because we didn't have any studies on 3 of the 6 originally targeted strategies. So studies of COPE and SBMR that were not in the larger database should be examined, and of course there are new studies on improvement collaboratives as well, so we would want to include those as well. For accreditation, it might be necessary to recognize that it's often implemented with other components, and we do have studies on accreditation in our database, and so maybe it needs to be studied as part of a multifaceted intervention, and the idea of accreditation only, just maybe that realistically is just not there. Second, the effect sizes for improvement collaboratives, especially with training, tended to be larger than those of other strategies, but you have to interpret these results with some caution because of high risk of bias and some evidence of limited generalizability. For training and supervision, they had modest effect sizes, and it seemed that as if the combination of training plus supervision tended to have higher effect sizes than either alone. Unfortunately, the results of the category with the largest effect size, which was high-intensity training plus supervision, also you have to be cautious about that because those were all high risk of bias studies. To increase the effectiveness of strategies that include training on multiple topics, it may be beneficial to have a duration of at least 5 days, with additional days potentially increasing effectiveness. And to increase the effectiveness of strategies with supervision, it might be beneficial for the supervision process to explicitly include provision of feedback to healthcare providers. In settings that are just on lay health workers or community health workers, there are very few studies and more are needed. And actually more exist, but they're just not in the database. And the effectiveness of training for lay health workers was not too different from that from other cadres. The effectiveness of supervision was greater, but it was just one study, so I'm not quite sure what to, I wouldn't put too much on that. And then finally, some just general recommendations and a concern. First is that really more studies are needed with stronger designs. I think that's really quite clear if you really want to answer this question in a satisfying way. And if USAID and others are interested in which strategy is sort of quote unquote best, I would go ahead and recommend conducting a head-to-head trial, because that provides stronger evidence than the indirect comparisons that I've been presenting. And then a question / concern: if studies are done, additional studies are done, who should be conducting them? And just a question, is there a potential conflict of interest if an organization is evaluating a specialized strategy that they're paid to implement? Should the evaluators come from a different quote-unquote neutral organization? So not saying that there is a conflict, but just want to put that on the table. And then clearly, this choice of strategy depends on a lot of factors besides just effectiveness, so cost, feasibility, and acceptability, and I think these need to be better assessed. And a few proposed next steps. Maybe I'll just skip this so we can get into the Q&A. And if anyone wants a copy of the database, send a very nice email to Samantha Rowe. There's her email. Give us a few bits of information, and we'll go ahead and share a beta version of the database with you. So a huge thanks. That was a long presentation. Thanks for your patience.